Good morning. Thank you so much for joining us today. We're so fortunate today to have Richard Palma here. He is the Director and Clinical Coordinator of the Duke School of Medicine Cardiac Ultrasonography Program. So what we're going to do today is he's going to talk a little bit about the athlete's heart and sudden cardiac death. His presentation will probably go about 45 minutes or so, and then we're going to leave some time for questions about his presentation. And then afterwards, he's going to talk a little bit about the Duke Cardiac Ultrasonography Program in case any of you are interested in participating. And then we'll have time afterwards for you guys to ask some questions. We also have some former Appalachian State students here that are currently in the program. So if you have specific questions for current students, they're here. And also on your way out, we have a QR code outside the door. If you can scan that and give us some feedback, we'd love to hear what you have to say about the talk and if you have any other thoughts about it. So.
All right, thank you very much. Thank you for the invite. I appreciate you, Becca, very much for letting me come here. Finally get to come here in person. I've been wanting to come down and visit everybody app, and I've had a few students so far be in my program and heard some great stuff, watch a lot of the college day football and different things. So it's a really popular place, and people, I just relocated to North Carolina 3 years ago. I'm originally a Bostonian, so you'll pick up my Boston accent a little bit. And so this is kind of a hot topic, obviously, from the Buffalo Bills player that had the incident, and we'll talk a little bit about him later in the talk. But we want to basically go over, come on now, you can do it. Go forward, go forward. Let me just click this maybe. Okay, maybe that's will work. Good. So we're going to talk about athletes and how we see them in the cardiovascular medicine area, and basically talk about how the heart gets remodeled from exercise, the different types of remodeling that occurs with athletes, the different types of athletes, and what kind of remodeling we see. Then we'll talk about chamber sizes, because we obviously have to look at the heart itself and what effects that occur at the heart. Then we'll talk about sudden cardiac death. So when we talk about athletes and we first start seeing them come to the hospital, the main kind of things we see are patients who are symptomatic first. And symptomatic would be things such as syncope, where they obviously would pass out on the field and things like that. Could be arrhythmias, arrhythmias that we document, arrhythmias we may not document. It could be coronary disease, and we'll talk about specific coronary disease that certain athletes could have. And then it could be hypertension. And then a lot of it is decreased stamina. So you might see some of your athletic trainers have athletes come in that just are not feeling like they're performing really well. And they may have had like mono or viruses or things like that that have caused them to have decreased stamina. Then we have the asymptomatic patient. And this is what's really interesting. We'll look at these people who are asymptomatic and we'll see they have really big hearts. We want to know, do they have an athletic heart? Or do they have a heart that actually has some pathology involved, meaning born with certain pathology? Could be an infiltrative type of disease like amyloidosis or hypertrophic cardiomyopathies, et cetera. And unfortunately, the last thing you'll see is the first presentation may be like sudden cardiac death. So they die on the field. So that's the first presentation. So those people obviously don't know that they actually have some form of pathology that was undiagnosed. So we started thinking about cardiac remodeling. There's pretty much two separate types of athletes. I know that a lot of you guys would say, well, there's a lot of athletes out there that are kind of a blend of people who are very cardiovascularly fit. I think of cardiovascularly fit, I think of them as more endurance athletes, people that do long-term, heavy volume of exercise, meaning large cardiac outputs for long sustained stuff. So those are the people who obviously are runners, distance runners, marathoners, et cetera. People who might be playing soccer. I know soccer obviously has stops and goes, but people do a lot of running, biking, rowing, et cetera. But then we have athletes who are strength athletes, right? Power athletes. These are people that do really high, intense, short interval type sprinters, football players, weightlifters, et cetera. So we see different types of cardiac remodeling. So this is an echocardiogram. So we are the first line of defense when it comes to assessing people with heart disease, obviously. So seeing someone's heart is really important. So what you see on your left here, and hopefully my arrow work, this is a picture of the first picture we typically take of someone's heart. This is the left ventricle, left atrium, mitral valve, aortic valve, ascending aorta, and the right ventricle here. And this is a normal person, normal wall thickness. And it's over here, this is a patient with hypertrophic cardiomyopathy. So hopefully you can see the difference of these walls. These walls are markedly thickened in this patient. So for example, there's the walls of the left ventricle in a normal person. This is someone with hypertrophy. Typically about 1 centimeter, 1.1 centimeters, a typical thickness of the left ventricle. And this person to the right has probably twice as thick. So this is someone that obviously has the diagnosis of hypertrophic cardiomyopathy. So as I mentioned before, these endurance athletes, they have high sustained cardiac outputs, right? So we think of cardiac output as typically 4 to 6 liters per minute. These guys obviously exercise at a very high rate, 10, 12 liters per minute a lot of times. Then we have strength athletes where you get a lot of this high intense, high blood pressure. So you'll see more of those athletes have the thicker hearts as compared to the dilated, volume dilated hearts of the patients who have volume challenge versus pressure challenge. So this is a great diagram showing obviously the normal heart. Then you see obviously the endurance athletes. So this picture shows the right ventricle and left ventricle. So when you think of an endurance athlete, it makes sense that they have a lot of flow coming back to the heart. So their right heart receives a lot of that venous flow, and they obviously pump out a lot of blood. So both their right and left ventricles dilate due to all this exercise. Where on the side you see of the person who's a strength training person, usually their right ventricles are quite normal, but their left ventricles, you can see, are more markedly thickened because this is more of a pressure event versus a volume event. So the question comes up, is that gray zone? Sometimes we get patients who may have, a little bit of hypertension. So you may say hypertension definitely causes left ventricular hypertrophy. Other things like aortic stenosis, anything that causes a pressure overload, coarctation of the aorta, et cetera. These can cause remodeling of the left ventricle, causing hypertrophy. But so you have to kind of figure out, is this person exercise-induced thickness, or is it pressure related to other diseases? So it is kind of that gray zone with the health versus disease. So as a medical person working at this, the first thing we have to do is really kind of understand, which we mentioned already, how the remodeling occurs. Then we had to do a really good medical and history. So when we start seeing people like the mother or father or grandfather pass out suddenly or died at age 40 of undiagnosed, we get a little nervous that they could have some genetic factors that could cause their sudden cardiac death. So then we do a 12-lead EKG. 12-lead EKG, as you well know, tells us a lot about the rhythm, maybe potentially the thickness of the heart and things like that, but it's not as super sensitive. So usually the 2D echo, which is what you just saw a minute ago, is obviously the first go-to visual of seeing someone's heart. Is their heart structurally normal? Meaning, is the heart valves okay? And I'll show you some diseases that could show up as an abnormality. Is the walls thick, chamber sizes, et cetera, which we measure. Then we could go on to some advanced imaging, transthoracic, adding what we call a strain imaging, where we actually look at the myocardial fibers to look at fiber disarray and actually look at the contraction of the muscle to see if there's any deformation abnormalities. They can go on to cardiac MRI. MRI is great for scarring. So there is some athletes, which I'll show you, that could present with myocarditis and have viral scarring of the hearts that causes them to have sudden cardiac death. So we like to do exercise testing, obviously, because that tells us how they perform when they exercise. We like to look at the EKG, look at the exercise tolerance, maybe do full, max VO2 tests to see how they are metabolizing, how they're doing really well. They may also do monitoring like Holter monitors to see if they have any, arrhythmias such as SVT or arrhythmias VTAC, et cetera. So those things, then we, like I said, we can go on to genetic testing. And then what's interesting enough, and I've been to a lot of these big national meetings with the athletic people who, some of the world-renowned cardiology echo / people, for example, like Erin Begish, who's a really close friend of mine, who actually just left Mass General, but he was the Patriots, Celtics, all the Boston cardiologist. But he went to UConn for exercise phys, then went on to be a cardiologist, but he's written almost all the big papers on it. But they talked about prescribing deconditioning. So if you had an athlete come in, what's interesting, a big study out of Australia looked at athletes, and they found that between 18 and 20 years of age, that's when the most hypertrophy occurred in their hearts. And what's interesting, because most people, when they leave high school, they start going to college and they start lifting weights the first time. So I remember when I went to college, I was a track athlete. I never lifted weight in my life in high school. The first day I was in college, like, there's the weight room. I'm like, weight room for what? I'm a lung jumper. No, you're going to be lifting weights and et cetera, et cetera. So that's where you see a lot of the hypertrophy, especially football players. So if they see hypertrophy on echo and what have you, what they'll do is prescribe 3 to 6 months of not lifting weights and to see if their heart regresses. If the heart regresses, then they know it's exercise induced. If it doesn't change, we know it's a pathologic abnormality. So when they did many studies, this is studies even back in the early 2000s, they looked at a lot of athletes, 1,300 athletes. And what's interesting, we look about the enlargement of the heart. Most athletes you see that are in good condition, you saw almost 40% of male athletes in college have a dilated ventricle. Ventricles greater than the normal person's ventricle because of the exercise-induced abnormality. So you'll see that when they looked at it, even gender-based, females and males, still even females, 25% of these athletes have dilated chambers. So the question is, why is it physiologically happening? So I think we already mentioned a little bit, a lot of it is due to the extra volume of exercise that these athletes are doing. I think it'd be interesting to start seeing some of the CrossFit people, because the CrossFit people, definitely a blend of high intense, lifting and cardiovascular. So I would like to see a lot of studies in the future about how those hearts look, because they're definitely kind of a mixed breed of athlete for sure. But basically, we're going to see that these people have dilated hearts. And when we think of stroke volume times heart rate, which gives you cardiac output, the heart ventricle, when it contracts, a normal ejection fraction, the contraction of the heart is 55%. So you're saying, why is it 55%? If I had 55% of my test in Dr. Kappa's class, that'd be like a failing class. But obviously the heart does not contract 100%, but that reserve is there because when you exercise, there's more demand of your perfusion of your myocardium, of your body, you want more blood to be pumped. So our output increases with heart rate and stroke volume. So when we do exercise, and I'll show you some stress echoes, the heart chambers will get much smaller with exercise. The stroke volumes increase. So it's interesting how you looked at these lazy hearts. And I've seen, people, why am I drawing a blank of the famous bike rider? Oh my God. Lance Armstrong's echo. His echo is so abnormal. His EF is about 35%, which is almost like someone you would get a defibrillator to. But his stress echo is absolutely amazing. His ventricle is like 7.5, dilated. But when he exercises, his heart bangs away. So they look like, it's really interesting. We see a lot of athletes that have, we call lazy hearts. So at rest, because there's really no demand, right? When they exercise, they have EFs of 50, 45, 50%. But when they exercise, the heart responds really well. So that's why stress testing, stress echo is really, really important. So moving on. So this is an example. This is a 4-chamber view. So this is actually the apex of the heart. So this is left ventricle, right atrium, left atrium, mitral valve, tricuspid valve. And this is a normal heart. And we see the left ventricle obviously larger than the right ventricle. But this patient here has a dilated heart. You can see how large this left ventricle is. And even the left atrium, look how large this left atrium is. So this is obviously a much more dilated heart for sure. So what about the right ventricle? Once again, the right ventricle is really sensitive for all the extra volume coming back from these endurance athletes. So we see a lot of these endurance athletes, a lot of them, like easily 40 or 50% of them have dilated right hearts, big inferior vena caves because of the volume. And once again, it makes sense because they're doing so much exercise, so much volume related to that. So it's really interesting to see that. And also it's important recently with COVID, the right ventricle has been really interesting to us because we've seen a lot of people get the right ventricle end up having abnormalities. So interesting at Duke, because it's so conservative in general. But every single athlete that gets COVID could not return to play, soccer players, females, whatever, so you name it, golf, anybody, basketball players. We echo every single athlete that they cannot go back to the field because they're afraid of, once again, any involvement of the right ventricle and any possible myocarditis, especially the younger patients. So it's very important that we screen all those patients. So we've done all the echo, all the athletes and basketball players, et cetera. So this is the right ventricle. Once again, you have the normal heart on your left. Then you see his heart here. This right heart is quite large. You can see how much larger. It's actually larger than that of the left ventricle for sure. So a dilated heart. So when it comes to that thickness of the wall, we talk about the athlete that has a lot of high pressure related, not volume related. So these people are more the isometric type exercises, people possibly with hypertension, et cetera, or they could have pathology. So we think of thick walls. What's interesting is we do have a cutoff now. We know with so much data that's been presented that when we look at athletes, a lot of these athletes will have thicknesses, potentially up to, you'll see right there, 1.3 millimeters or 1.3 centimeters or 13 millimeters. So I told you about 1.1 is normal in general, but 1.3 is obviously 0.2 millimeters, a little thicker. So that's been seen in a lot of the athletes. But the key number that we see is that when they did some major studies, there was not one athlete, I don't care what kind of shape they're in, weightlifter, et cetera, no one exceeded 1.4. So we have a cutoff now in general, just to be even more careful, is 1.5. So anybody that has anything over near 1.5 for a wall thickness, that is pathologic, meaning there's some hypertrophic cardiomyopathy in those patients. There's no way any athlete's going to get that thick. So that's why it's so important we image these patients by doing cardiac ultrasound, because that's really important, because you're going to see the leading cause of sudden cardiac death is these patients with hypertrophic cardiomyopathy. So as I mentioned before, this is obviously due to the increased pressure from exercise. And once again, the cutoffs, and you can see that 1.55 is, once again, anything over that is pathologic. So if we see a person come in, we talk about this gray zone of like, is it an athlete's heart or is it actually a diseased heart? This is one of the key things that cardiologists look at and say, if it's over 1.5, that is, this young person does not have an athlete's heart for sure. So I mentioned earlier about many publications, there's actually a few more actually out talking about detraining. So if you're really concerned, you have someone hovering around 1.3-ish, and you're thinking, well, it has to be maybe exercise induced. So they're recommending, up to 3 to 6 months of deconditioning, no lifting. Just like any muscle in the body, if you don't lift weights, you get atrophy, right? So the same thing can occur to the heart. So a little bit of a summary as far as the athlete's heart goes. We obviously can talk about the hearts that have normal thick walls. And these are all the different reasons why people could have a thick wall. And once again, if you look at the differential diagnoses, if we're looking at thick walls, we're thinking obviously it could be some, either hypertrophic cardiomyopathy, hypertension, heart disease, infiltrative disease such as amyloidosis, could be some valvular disease. Then we have other things like, what are the other things related to this person? This athlete probably is going to be a strength athlete that does a lot of all that kind of stuff and a family history of anything going on. So we're going to look at the echo parameters, the measurements of the heart, and then we may do some other further testing. If we're looking at somebody with a dilated heart, we're going to look at things like, does this person have a virus? I remember echoing a guy that was a lineman back in Connecticut, and he was an arena football player, lineman, and he passed out in the field. And we didn't echo on him, big guy. And I remember his EF was like 45%. And I'm like, geez, he's a lineman. He's not like this, really good, phenomenally conditioned athlete. And so we ended up doing some monitoring for rhythm wise. He was having a lot of rhythm, like VTACs a little bit. So we ended up, finally talking to him, and he admitted that his junior year, he ended up getting mono, and he ended up developing this viral cardiomyopathy. So then, 2 months later, his EF dropped to 30%. We ended up putting a defibrillator in, and he didn't play football anymore. So it's interesting how a virus can affect that. We see quite a bit of alcoholic cardiomyopathies. which is really interesting. So alcohol can definitely do that. A lot of viruses, oh my God, tons of different viruses can affect it, especially when you start thinking about even COVID causing scarring of myocarditis. And then we have people who have sometimes a lot of tachycardia. Anytime you have prolonged tachycardia, you can develop a tachycardic cardiomyopathy because your heart gets burnt out from beating so fast. So we look at the history, the endurance type backgrounds. So we also looked at other things as far as the chamber sizes, and we'll do additional testing on them with exercise and cardiac MRI. So if you have somebody who has the dual dilated right ventricle also, we're going to look at a lot of things like a potentially very deadly disease called arrhythmogenic RV dysplasia. It's one of the 4 cardiomyopathies recognized by the World Health Organization, along with dilated, hypertrophic, and ischemic cardiomyopathy. So they may have also things such as pulmonary hypertension or congenital abnormalities of their right heart. They could have an atrial septal defect, hole in the heart, right? So look at Dave Goggins, the super athlete. You've heard Dave Goggins, I hope. Little did he know that after many years he was exercising, he's like short of breath. He finally had an echo done. They're like, "Do you have a huge atrial septal defect?" He's like, "Oh, I do." They finally closed it. He's even better, which is amazing. So sometimes you have congenital abnormalities that can affect that for sure. So once again, we're going to look at the family history, look at the exercise intolerance. We're going to look at other things as far as the chambers, and we'll go on to some of those other things like signal average testing, EKG, exercise testing, cardiac MRI. So this is an example of a stress echo. So a stress echo is kind of cool because instead of doing an exercise test just with EKG, which has a sensitivity and specificity of, depending if it's male or female, anywhere from 75%. When you add imaging into it, like nuclear medicine, now stress echo, so we actually will take a baseline image of the heart, which you'll see on the side. This is the resting images on your left. This is the exercise images on your right, is that it'll capture just systole. So it'll capture on the EKG, the QRS is end diastole, physically, not electrically, and it captures all the way to the T wave. So it catches systole of a heart rate of say 70. Then what happens is we'll take images after exercise within about 30 seconds to a minute when the heart's under stress, and then it captures the heart. This heart rate may be 180, but it actually captures only systole. So we can put them side by side. You can see, for example, on the right, how much that black space in the middle right there, how much it's getting smaller. So this is resting. You can see how the ejection fraction goes up. So here's an example of a 4-chamber view, and you'll see like this ventricle right here, this is at rest, normal. You can see how dynamically this heart is contracting. This patient has pulmonary hypertension though. So what happened in this case, this is the right ventricle, which is slightly dilated at rest, but during exercise, it actually dilates. So it tells you that when the extra demand was put on the right ventricle, which typically deals with blood pressures in around 25 to 30 millimeters of mercury, unlike the left ventricle that goes anywhere from like 100 to 250, it's not used to that high extra pressure and volume, so it can acutely dilate. So this is actually a patient with a hypertrophic obstructive cardiomyopathy. So I don't know if you can really see how markedly thickened this wall is here. So when we talk about HOCM is a hypertrophic cardiomyopathy, but the O stands for obstruction. And we'll talk a little bit about that. But what they typically have is, you can see this septum right here, how thick it is as compared to the back wall. So we define this as a little bit different. This is called asymmetrical hypertrophy, meaning that one part of the heart is thicker than the other. Typically, you have concentric LVH. That means the walls are normally thickened all around, but this is actually an abnormality, and it causes obstruction, which I'll talk about in a little bit. So when we think of the athlete's heart, it's important, can we actually separate that pathologic person from the athlete's heart? So we definitely know the answer, right? If a heart is greater than 1.5 thickness, 1.5 centimeters or 15 millimeters of thickening of someone's heart, that is not an athlete's heart. That is a no-brainer. But we do have to consider what type of athlete we're dealing with, meaning, is it an endurance athlete, a pressure intense working athlete? and look for those typical remodeling. But there is going to be a lot of extra tools that you may have to break out. So when they come to us, it's pretty scary because they're having symptoms or there's something that might have happened on the field. They might have passed out or something. So it's for us, we have to use this toolkit and look at all the different measurements of that. Any questions about the athlete's heart before I move on to, I'd be happy to take questions as we're going along. Shy people? No. Yo. A Steeler fan. Okay, sorry. Yes. Yeah. Yeah. I mean, the syncopal is really important. The question is, why does someone have syncope? And that is basically a lack of flow to the brain. And that can be because of obstruction, such as a HOCM, aortic stenosis. It could be actually mitral regurgitation. Someone can have acute mitral regurgitation that as the ventricle contracts, the blood should go out the aorta and actually goes back into the atrium. So any loss of fluid, it could be vasovagal, could be the brain not talking to the body, right? So, picture people doing, why am I drawing a blank so much? I need this coffee like really in my body. Burpees, like burpees, you're up and down, and people like, sometimes their body does not respond very well to burpees. Alignment is down and he's up, he's down, he's up, he's down, he's up. So could he have a syncopal episode from that? There's lots of reasons. So we have to figure out what is the mechanism. And first of all, is there structural abnormalities? Is there neurological things going on? What kind of physiologic things could be occurring? He could have other abnormalities. That's why further testing would have to occur with, EKGs, rhythm monitoring over certain times. So it's not as easy. It's not just like, oh, he probably just has that. Well, you can't just like hypothesize that this person has it. That's why seeing someone's heart, I'm very biased. I mean, there's lots of we're talking about sudden cardiac death in a little bit, but should we scan all athletes? There was talk about in Italy, about all high school athletes getting EKGs. You know how much money it costs to do an EKG in every single high school athlete? That's a lot of money, even though EKG is kind of cheap. Echo is not cheap. But echo screening wise is amazing because it's going to rule out dozens of abnormalities for sure. And it's always funny, let's see like a kid that dies in a local neighborhood and everybody's like demanding that we do echo screening in the community and stuff. And a lot of us love to do that in schools. We'll go in and scan, things, but look for abnormalities. And it's interesting talking about screening in general. So example, like, when I was up, at Mass Gen Aaron, I've asked him a bunch of times, like, I would love to scan Tom Brady and the whole crew, and Bill Belichick is like, no, you're not coming near us, right? And a good example of this, which is kind of interesting, is Teddy Bruschi. Teddy Bruschi's probably in ESPN quite a lot. Teddy, right? I'm a big Patriots fan, so whatever. But so what's interesting is Teddy was pretty PO'd that he never got scanned. But when he made the Pro Bowl many years ago, he flew to Hawaii. The Pro Bowl was in Hawaii. He had a stroke on the plane. He came back. Aaron saw him. He's like, do you know this echo shows you have a hole in your heart? He's like, no. So he had an atrial septal defect, had a paradoxal embolus. And he's like, I wish I'd known that. And he went back to Bill and said, why can't we all be screened? He's like, no, I don't want my athletes being screened because why? They're in major contracts. And what happens if they find out that, what if Tom Brady had, Holcomb, which he probably wouldn't have, but I'm saying, what if he had that? It'd shut him down, So it's interesting how it's like, don't tell them, don't speak, don't tell. It's like really interesting how they don't want that information out there, which we'll get to a little bit. Was there a question back there? Sorry, go ahead. I thought it might have been raising the hand, or maybe it was a yawn back there. Okay, another question. Yes. Okay, I'm sorry. You were just yawning. Okay, good. Any other questions? Hope they answered the question. I don't know if I did or not. I rambled for a little bit there. Okay. Yes, doctor. Oh yeah. Oh, Yeah, I mean, I've shut down a major football player for the Patriots. It's actually came out, but Tabucky Jones was a local guy in Connecticut that played for the Patriots. He was a safety, went to Rutgers, won a Super Bowl with the Patriots. So he finally admitted, well, I guess a lot of his teammates just started like saying to the coaches, like, you know, Tabucky is like out of control. Because he would scream every time he hit somebody. And it was like, why? And he's like, oh, he finally admitted he had crushing chest pain. So when he went to hit somebody as hard as he could, he would feel chest pain for 5 or 6 seconds and he would go away. And so Bill's like, I don't know, he's fine. He's never, we don't need anything. So he finally decided to have an echo done, normal echo, had a stress echo, and it was normal as can be. Guy's a phenomenal athlete. And then, so we I work in a special place with back up in Connecticut that did a lot of athletes. And so he came to us. So we did a stress echo. We pushed him like 140% of max heart rate, symptomatic as far as you could go. We laid him down. He had a Walmarsh abnormality the first 3 seconds and went away, which is interesting. So long story short, went to the cath lab and he had what you're going to see. He had myocardial bridging of a coronary artery between the aorta and the pulmonary artery. So during intense high pressure, his left main coronary artery got completely compressed. And we relieved that stress of the pain when he valsalved, didn't put down. The pressure went away, uncompressed. They're like, no problem. We can fix you. Open heart surgery. We'll resect your coronary artery. We'll reinsert it. Not a big deal. He's like, you know what? I've been playing I'm 31. I've made millions. I'm done. I don't want to have open heart surgery. It only happens when I do crazy intense. So I'm good. But it's funny how like these coronary abnormalities, which we'll be talking about, can be out there. So he was pulled off the field, and there's a lot of people, athletes who have Holcomb, for example, large aortas that have basketball players that could have dissections, right? So you'll find out they have it, and we tell them you shouldn't play basketball anymore, right? So, okay, we'll move on because I'm trying to make sure I fill the time really well. So we're going to talk about this. So this is kind of a hot topic as of late, as you can imagine. What's really interesting is that when it's in the media, it becomes a big deal, right? Obviously, if anything was bigger than that Buffalo Cincinnati game, I don't know, because that was Monday night. All eyes in the world were on that game when that happened, right? So that definitely brought up like, what? This guy is a great athlete. How could this happen? He definitely did have sudden cardiac death. There's no question about it. We'll talk more about that. So it's just really interesting how it really, when you look at the actual percentages overall, number-wise, it's a really crazy small number. But because it happens, it just is just so magnified, right? Does that make sense? Like how many athletes you have here at AAP, right? A lot, right? How many have you seen die on the field? Not many, right? I mean, over the years, right? So it's amazing. It looks like when you watch TV, it's like everybody has this, right? Probably someone's going to die of it. So we're going to kind of basically talk about the causes of it, which is important. And we're going to try to talk a little bit about differentiating the diagnosis of this, and then talk a little bit about the overall numbers, and then kind of screening a little bit, which is important, and other things. So when they define an athlete's heart, I should have probably started with this here. It was actually Dr. Henson way back in turned athlete's heart was initially thought to be some form of heart failure because the heart was thicker or dilated. So anything that was abnormal, they thought it was failure, right? Failure to work. But we know now, and you don't know this, but in general, there's patients who have congestive heart failure. And a lot of people think congestive heart failure is the heart is actually what? Not pumping very good. But you'll learn, and my students know this here, that there's two kinds of heart failure, systolic heart failure and diastolic heart failure. So systolic heart failure means that the ventricle is not squeezing very well. Diastolic heart failure is when the ventricle isn't relaxing very well. So if you don't fill your heart, you can't get the blood out. So people who have stiff, non-compliant left ventricles, they, from hypertension, other diseases, amyloid, et cetera, they have diastolic heart failure. They have normal ejection fractions with abnormal relaxation. So it's not always about a bad pumping heart. It could be a bad filling heart. So echo is like right in the forefront quite a bit. And we're going to look at the wall thickness and stuff. So when we talk about EKGs in athletes, we can do EKGs in athletes. And what we're looking for is lots of little things. But basically what we're looking for is there some some strain pattern or hypertrophy pattern on the EKG. Could there be some repolarization? Possibly, hopefully not ischemia, which would be ST segment depression, obviously. ST segment elevation to be injury. Some kids may show with chest pain that pericarditis. The heart's normal, but the pericardium is inflamed. So this is showing EKG. This is someone with hypertrophy. So basically what we're doing is taking V1 and we're measuring V1 and measuring obviously the S and the Y. And if over 35 millimeters, that would be indicative of someone's thick heart. But is this super sensitive? Does it show asymmetrical hypertrophy? No. But could it show hypertrophy? Absolutely. So you can see also some T wave inversion in this patient too. So that could be kind of a strain pattern on the EKG. And this is showing obviously the precordial leads V2 through V6. So you see that they have that kind of abnormality of the left ventricle as the EKG goes around, obviously the apex of the left heart. So once again, because of this, we see that a lot of these are caused by a lot of these congenital abnormalities and cardiovascular abnormalities. But in the general population, people are not dying of sudden cardiac death. So yes, TV exploited this quite a bit, but in general, it's very, very uncommon, right? So look at this, like if you look at the younger person versus the older person, right? So when you're looking under 35 years of age, why would someone die of a sudden cardiac death? So 36% of the time is because of a hypertrophic cardiomyopathy. Then we have 19, almost 20% is coronary artery abnormalities, right? Then we have like some either cardiac mass, like a myxoma, et cetera. And we have all these little other abnormalities. You see mitral valve prolapse, arrhythmogenic RV dysplasia, myocarditis, et cetera, aortic stenosis. But for someone that's over 35, it's definitely going to be coronary disease. So when we see the younger person, most likely it's going to be hypertrophic cardiomyopathy. Does that make sense at all? I mean, in general, hopefully. So when you look at this right here, this is showing the large study of patients who died. You can see the percentages right there. The largest is hypertrophic cardiomyopathy, the coronary stuff, or there could be ruptured aortic aneurysm. So the patients that we typically get nervous about with the aneurysms are Marfan's patients. So Marfan's is a connective tissue disorder, so they can have rupture or dissections of their ascending aorta. So when we talk about hypertrophic cardiomyopathy, this is the single most common abnormality seen well over 35%. So this is why it's so important to image these people and to find out whether they have that. What's interesting about these hypertrophic cardiomyopathies is, and there was a really good article, actually it was in Sports Illustrated, which like, I don't know why this analogy came up, was way back when one of these high school football players died. And what's interesting is they talked about and explained this fibra disarray of the myocytes in the myocardium. And usually they did a really good description. I always keep on using it today, is that when you think about a brick wall, how the bricks line up really, really nicely. So if you took a bunch of bricks and you kind of threw them in a pile, they'd be all over the place, right? All different angles and directions. So that's called fibra disarray. So people with these hypertrophic cardiomyopathies, within their myocytes, they have fibro disarray. This fibro disarray can cause a lot of these VTAC, VFib, sudden cardiac death arrhythmias. So that's why it's so important to figure out whether they have this hypertrophic cardiomyopathy. So they can also have this thing called an outflow tract obstruction. So this outflow tract obstruction, that's what the O says, hypertrophic obstructive cardiomyopathy. So it's not just a thick wall. They have what we call as asymmetrical hypertrophy, and not to get too technical on you, but this extra hypertrophy in the septum, and we have a left ventricular outflow tract here. It's so thick that the blood, instead of going straight out, has to kind of go around this big septum. So there's a thing called the Venturi effect. The Venturi effect, the same thing that lifts airplanes off the ground. It actually accelerates through the septum and causes that anterior leaflet to actually slide upward. So it has dynamic outflow tract obstruction. So we will do things like a Valsalva maneuver to decrease preload to accentuate someone's outflow tract gradient. Or we can also use amyl nitrate, smelling salts. Now we'll do the same thing. So, which I'll make a point a little bit later about that. But so what's interesting is that this obstruction, the first couple of HOCMs I saw, these couple of football players came in with, they had a cheekbone broken, a nose broken, because they were bench pressing or doing dumbbells. They're holding their breath and they dropped the weight in their face. So when they Valsalva, they decreased the venous return and they basically completely obstructed the outflow tract and they pass out. So this HOCM is really important. We do lots of things to look at them. These people end up having sustained VTAC, VFib, sudden cardiac death. So really bad. That's why it's so important to diagnosis. So we started thinking about some of these players like Jason Collier. He was one of the guys that who ended up having that. Really famous person was Hank Gathers. Have you ever read about Hank Gathers, Loyola Marymount? So he was a really interesting case. Diagnosed with hypertrophic cardiomyopathy, medically treated, right, with beta blockers, and he started playing his senior year, and he was, beta blocker obviously slows the heart rate down. He's trying to run up and down the basketball court, and he was struggling because, once again, you want your heart to beat faster to get record. So he unfortunately wanted to do well and maybe get to that next level. He decided to start taking a little less medication. His points went up a little bit, more rebounds, felt a little bit better. By near the end of the season, he was playing really well off his medicine, and on the free throw line, dies. Sudden cardiac death on national television, flat on his face and dies. So known hypertrophic cardiomyopathy, decided not to take medication. Reggie Lewis, good friend of mine. I went to college with him. I was an All-American. He was an All-American basketball player, played for the Boston Celtics, caught a virus. Dr. Mudge at the Brigham made the diagnosis, cardiac MRI, scarring through his whole heart. He was having episodes of VTAC, VFib, fainting. So he was scheduled on a Tuesday to have his defibrillator put on. That Sunday, he died out in Waltham at the training center. They did not have an AID machine at that facility, which is crazy. So, another person, Pistol Pete Maravich, one of the best college players in the world, had a single coronary artery. How would you know that? Way back then, didn't have echo, right? Famous player. So he died at 40 years of age, had a coronary spasm. His whole heart died. So that's congenital abnormality. So interesting enough, this is the guy that's been the hot topic, right? You may not want to hear what I want to hear say about this, but has anybody ever heard like his diagnosis yet? Has it ever been a medical person to ever say that word? No. Has they come out and now the doctors? Yeah. Has there been any cases? He had sudden cardiac death. That's all I say. We all know that. We saw him die. Why did he die? What was the cause? There's been zero information about him. Zero. I know he's been echoed. He's had everything done to him. If he had hypertrophic, tell us if he has that. No one's said a word. What's his drug panel like? I'm just curious. I don't know. I'm sorry to stir the pot a little bit, but the Twitter went a twit when the following week, when Josh Allen was on the sideline, getting ready to come in. He did amyl nitrate on the sideline. My whole cardiology Twitter went wild. Why is he doing why is he doing smelling salts before? That causes obstruction. I mean, why is he doing that? Like, what else are these athletes getting? The athletic trainers are refusing to speak about anything. Really interesting. Oh, I have no idea. No idea. We don't know. Yeah. If this was this, should the NFL change the equipment then? Has there been any talk of changing the equipment? Do they actually cover the chest with it? I'm just curious. Oh, yeah. Has there ever been a ever been like a football hit ever? Like, yeah. So there's the ones that you get. Those are the ones you typically get this disease, no question about it. And usually when you get hit, it takes a little while before you have arrhythmia. For him to have that instantaneously, like I said, all of us in the community know that it's like, there's no way in God's green earth it was that. That's why the question mark's there, just to let you know. And once again, if he was a hypertrophic cardiomyopathy, he'll never play again. He's getting a defibrillator, he's never playing, but he wants to play next year. Mum's the word, he can play. Just let you know, I'm not to put it out there, but just let you know. So once again, we talked about this. I'm not going to bore you, but it's hypertrophic. But this is a normal heart, and look how thick that heart is. This is a thick heart. So look at the thickness of that. That's like super thick, right? So this is Holcomb. So I want to point out is that this is the asymmetrical. Let me point this way. This is that asymmetrical thickening. But see this mitral valve? You see how it's kind of like bumping up and hitting that septum right there? So when this in systole and this contracts, see how small this area is? This blood gets obstructed. So what you'll see is that the black is blood. So we can visualize that in color. And what you'll see here is this color is colorful. This is called aliasing. This aliasing is because there's obstruction to flow in this massive hypertrophic obstructive cardiomyopathy. So they completely obstruct the outflow tract and they pass out. So like I said, running, if you snip the smelling salt, which is obviously amyl nitrate, it'll cause you to have syncope. You make a hit, get up, you pass out. So like I said, everybody's like, he has Holcomb probably. There's no doubt, but he's not in, no one's ever said anything yet. So congenital abnormality is the second most frequent, and that's close to 19 to 20% of abnormalities. And we know that coronary arteries come off the ostiums of the sinuses of Valsalva. And once again, the 12 lead EKG doesn't tell you about coronary abnormalities whatsoever. So what you'll see is that, they can come off of different cusps, and I'll show you a picture of that. So this is typically, this is the right coronary cusp. This is the left coronary cusp. So you have two main coronary arteries. This is the right coronary artery. This is the left main coronary artery that bifurcates to the left anterior descending, and the circumflex artery. So they typically come off of these two valve orifices. This is called the non-coronary because obviously coronary does not come off. So we visualize that by echo. This is showing the aorta. This is showing the left main coronary artery. This is the LAD, and this is the circumflex artery. So we can visualize coronary arteries. So every athlete that I scan, I make sure that I look for coronary arteries, look to make sure they have two coronary arteries. There is a bifurcation in the left main, and make sure there's no anomalous origins. It can be lots of different origins of these coronaries. And then also we'll look at the right coronary artery. You can see the right coronary artery coming off. This is the proximal portion of the right coronary artery. Some babies could have, let me go on the blank. No, oh yeah, I'm getting to that. But the Kawasaki's disease, which is aneurysms of the coronary arteries too. So these are the many different types of abnormalities where you can have literally a single coronary artery coming off and then bifurcating into two. You can have one that goes in between the aorta and the pulmonary artery that causes that compression that you can see. We also have some other bridging that occurs where you can actually go within the myocardium itself. Sometimes it can go wrap around. So all different kinds of abnormalities. That's why these people should have CTs, MRIs, angiograms to see why it is and why they may have those abnormalities. So myocarditis. So we're seeing a lot of this now with athletes, with obviously younger people, maybe with COVID. So that's why we're screening them more and more and more. And these people can catch a virus from anything. Why someone has strep and why it affects their heart and why it doesn't affect somebody else, that's a whole different topic. But in general, it's interesting how it can affect the heart, causing that scarring in the heart. So like Reggie Lewis ended up having that scarring and he died. So long-term other things such as cocaine use and stuff isn't good. When you think of medication-wise, if you guys look history-wise, because I'm a Boston Celtics fan, is that one of the things that killed us for about 12 years was we ended up getting probably the most athletic basketball player, like before LeBron ever came on, the guy named Len Bias. Len Bias from Maryland was a freak of an athlete, got drafted. A bunch of buddies say, hey, come party with us. Did cocaine for the first time, coronary spasm, died. Put back the Celtics by about 10 years, like terrible, So doing cocaine, not a good thing either, right? So aortic rupture. So if your ascending aorta is dilated, and it's not as strong, obviously, as it gets spread out. Think of a balloon. The more you blow a balloon up, the walls are thinner. Is a potential to dissect or rupture. So a lot of people, the famous person was the USC volleyball player Flo Hyman that dissected while playing volleyball. She ruptured, she had Marfan's abnormality. So she had aortic dissection. So this is what we call a bicuspid aortic valve. So you have 3 leaflets that you saw already of aortic valve. This is the most common congenital defect in all of adults. So our poster child for bicuspid valve was a guy that was pretty fit named Arnold Schwarzenegger. So Arnold Schwarzenegger, pretty good shaped guy, right? Overall. So he ended up, having a bicuspid valve, and usually a bicuspid valve falls apart around the age of 40-ish to 45, either leaking or stenotic. So his valve, because also he did steroids, but his valve fell apart. He ended up having a thing called the Ross procedure, where he took his pulmonic valve, surgically placed in the aortic valve, did a bioprosthetic valve in his pulmonic valve, but he continued to do steroids. And so that valve went bad. So then he had his second surgery where they put a mechanical St. Jude valve in. And that's why since then he didn't do any more action movies and jumping out of planes and stuff. Because when you have a mechanical valve, you're on blood thinners, so you can't be jumping out windows. So this is an ascending aorta that's dilated. So if you have a bicuspid valve, the dilation of your aorta, you'll more likely dissect than someone with a normal valve. So this is another type of test that we do called the transesophageal echo, where they actually place a probe down your esophagus. We can see the heart because your esophagus is right behind the left atrium. So this is actually showing the ascending aorta. You see that little line right there? That line is an intimal flap. So by definition, aortic dissection is a tearing away from the intima, from the media and adventitia, where the column of blood is actually flowing through that area. So this is, especially if it's the ascending aorta, that's an emergent surgery, because if you dissect or rip up, you will lose your subclavian, obviously flow to your brain. So you have to have that done. Descending dissections are usually treated medically, but surgically, ascending ones. So the next one is one of the type of cardiomyopathies that's very, very much hereditary. That's called ARVD, or arrhythmogenic RV dysplasia. So this is a fibrofatty replacement of the myocardium. So instead of having muscle in there, you actually have fat. And it's interesting, if you talk to people who are pathologists, the diagnosis initially was they could actually take the right ventricle and slice it. They can put it up to the light. You could see through the heart. That's how thin the heart was. And these people, because of the thinness of it, and also because there's fat in that area, they are typically used to having VTAC, VFib. So when you make a diagnosis of ARVD, which a lot of times we don't see it initially, because we see it when someone does pass out or actually dies in the field, we'll see it after they come from the EP lab. But if they do have it, we put obviously a defibrillator in, because that patient's really prone to having lots of VTAC and VFib. So this is a picture of this, and you can see the arrow pointing to that super thin right ventricle. See how huge that right ventricle is? That's a huge right ventricle. So if you ever see an echo like this on an athlete, obviously they're not, participating anymore, because they're definitely going to have a defibrillator put in for sure. So valvular heart disease is very uncommon, but I mentioned about the bicuspid valve. They don't really fall apart until age 40, but you could have aortic stenosis, or very commonly, especially in women, 2-to-1 ratio, is a thing called mitral valve prolapse. So what you'll see here in the arrow on the left is mitral valve prolapse. You can see that this anterior leaflet is bowing beyond this leaflet here. So it's actually bowing. This will cause mitral regurgitation, but it's also pulling the chordae tendineae into the myocardium. It's pulling, causing chest pain. A lot of females will have chest pain and be like, I have chest pain. And we echo them, they use that MVP. Then to the right, you see aortic stenosis. You can see this valve is normal, the aortic valve in this picture right here. See, it's opening nicely, it's nice and thin. This valve is thickened, calcified, not opening well. So that aortic stenosis causes obstruction to flow. Isn't it kind of neat? The echo sees a lot of things. So, when we think of absence of physically structure abnormalities, we'll look at EKG changes. So there'll be things like WPW, Wolff Parkinson White. Also, we'll have QT syndrome. You'll see a lot of young ladies may die in the night because they have QT syndrome. Or they could obviously just have VFib out of the blue, which is hopefully not not very good to have that for sure. And once again, when we think of people that don't have these stuff in young athletes, you have to kind of look at these non-structural things too. But if you look at the true prevalence, of this, the question is, it's really hard to determine because how do you know, how many people are really reporting, how many people are having autopsies if their kids die. So, but if you look at some best estimates, you're looking at 1 out of 300,000 athletes may have abnormalities. So should we scan 300,000 athletes to find that one athlete? I don't know. Economically, it may not, right? But I'm sure if you were the mother or father of that daughter that died, you'd want to have that done, right? So it's just really interesting, so when you start looking at like healthy people, it's pretty rare, to have that for sure. So once again, I think the news definitely promotes it, and you would think that every NFL player would want to echo, the following day, for God's sakes, right? But are they getting it? No, they're not. So demographics. So think about the sports. What kind of athletes are actually doing this, right? Do you think they're, ping pong players? Probably not, right? Obviously, they're basketball players, football players. Those are the most common ones. 90% are male, which I guess is good for females, right? So, but I do get nervous because there's a lot of SCAR out there, which stands for sudden cardiac artery rupture. And we see a lot with the cross trainers because they basically have spontaneous rupture of a coronary artery because it's so intense athletes. So I get nervous about women kind of doing cross training because it's just so intense for sure. So, but mostly men, obviously, mostly you don't see it often with less intense sports for sure, right? So when we look at the overall sports, these are the 3 big ones, right? Basketball, football, maybe track. You may see that, right? And other sports, not so much, right? And also looking at some of the populations, African Americans possibly have more of the hypertrophic cardiomyopathies also, but it's difficult, to look at that. So how do we screen these people, right? I mean, many high schools out there do a little history and physical. I remember when I was a kid, it was turn your head, cough to the right, check for hernia, you're good, move on. So they really listen to people's hearts. Are they doing really good? Are they doing EKGs and all the high school athletes? No, of course not. And the question is, are they really doing good screenings? And I know like a lot of our, my kids were in high school, they used to have a doctor give a good, physical from their pediatrician. But a lot of times, sometimes they just go, someone would just show up, a chiropractor, someone or a PA would do a quick, you look good, fine, move on. But they're not really doing great overall evaluations, I don't think, but truthfully, looking at someone's family history, if you have family history of people dying in your family, I would think that person should be looked on really closely. They should be scanned, they should have EKGs, all that kind of stuff, If you have a heart murmur, that should tip you off. There's some structural stuff going on, the dynamic murmur like HOCM or mitral regurg or aortic stenosis, all that kind of stuff. That's usually going to be related to some pathology. So once again, typically this is an older slide, but when you look at all the people that are actually doing some of these exams, there's a lot of different people doing these exams for pre-op clearance. It's not always a doctor doing it for sure. So once again, 40% of states and high school associated do approved high school physicals. There are deficits in major areas like the heart, obviously evaluating that. But like I said, there are a lot of states that have alternate clinicians. Once again, nothing wrong with the nurse practitioner. My daughter's a PA, nothing wrong with them. But sometimes they're not obviously doing in-depth evaluations of these people. So any questions before I do a couple of slides about our program? Is that interesting? You knew all that stuff already? Any questions at all? Yes. EP. Elevated levels. Yeah. Yeah. Yeah, I mean, so when you talk about like ectopy at rest, a lot of people, I get PVCs occasionally, right? They premature ventricular contraction. I'm sorry if you guys know this or not, but like any kind of benign, stuff at rest can be lots of just irritation for some reason, lack of sleep, etc. But when you put them on a treadmill, they will get suppressed. So I'm guessing you said elevate, I never heard the word elevation because unless we're measuring a blood level, which we're probably not doing. But the question is, are they saying that he's having more ectopy with exercise? If you have exercise-induced ectopy, that's usually indicative of some sign of electrical abnormality or coronary disease. So that's when that person would go on to have a cath or EP. And the question is, they may go for an ablation or something to kind of go in there and ablate an area that could be, or it could have SVT, maybe has runs of SVT, supraventricular tachycardia. So the question is, that's why we do exercise testing to see how does that person relate to exercise itself. So the difference is that, yes, there could be normal people, but we look at the same parameters. We look at heart rate, blood pressure, double pressure products. We look at all that kind of stuff when it comes to exercise with an athlete. Also, obviously, we think in general, an athlete will take a longer than shape to get to that maximum heart rate, right? So whereas someone who's deconditioned, it will take a couple of minutes to get their heart rate up, right? So they'll go deeper into a Bruce protocol versus, someone who's deconditioned or a normal person. But we push them a little harder too. We're not afraid. I hate when, like, I love symptom limited stress echo. I mean, the guys, I told the students about this. I'm like, this whole like, oh, we just get to the heart rate, let's stop. The person's like, I can go further. Why some people stop at 90%? Like, push them a little further, because that's when you're going to really bring out any potential abnormalities. And usually athletes, we don't mind pushing them. So maybe they saw him at peak exercise, started getting rhythms and stuff, and his heart gets irritated, and there's something going on underneath. Well, then, like if his heart structurally is okay, it's probably some electrical problem. That's why EP saw him, if I had to guess. That's how the referrals go. If it's a structural problem, he's going to a surgeon or whatever, an interventional. Then obviously, if it's an electrical problem, electricians are EP. So, yes, sir. Breaking out. No. Education. So educating them that here is the facts, the numbers, that it's not as prevalent. Not every high school this year is going to have a person die of sudden cardiac death. It's pretty rare, right? But if you think about one of the slides or two I talked about is doing a good history and physical, like look at people's family history is huge. Like, yes, not that all people, like obviously, like Hammond, for example, we don't know what his family history is, but is that the leading cause? Can you have hypertrophic cardiomyopathy without a family history? Yes. But having other things that alert you that this person has decreased stamina, or is having rhythms, or having things that ectopy, things that bother them. Unfortunately, I hate to say this, and this because if you coach athletes, they're very quiet about their injuries, how they feel, right? Look at concussions. You think everybody has a little bit of a head bump, runs over to the head coach and says, "My head hurts a little bit." I mean, they're going back in, correct? Am I not? I mean, no. I'm saying like, no. I'm saying like, sometimes they like, they get dinged up a little bit. The bell gets rung, and so whatever. I think a lot of times they hide, like they want to keep playing. Does that make sense? So unfortunately, you have to really tell them, like, if your son or daughter is feeling symptoms of things, you should let people know about this, because the last thing you want to do is it could be the preemptive curse of something happening worse. I don't know if that makes sense. Yeah. Okay. Any other questions, concerns? Somewhat entertaining, not entertaining? No. Quiet group, huh? It's like my echo class, like ask questions. But yeah, it's just really interesting. Like I said, we need to do a lot more screening. I wish, like I said, I'm biased. I think everybody should have an echo. I mean, it's a non-invasive test. It's no big deal. It's 20 minutes of your time, but you get so much information of your valves, your heart. It's a good baseline, huge baseline. It's so readily available, portable machines. We have handheld machines to scan, I've been to India and Indonesia where I've scanned like with just portable machines. It's like, it's such an easy mobile device that you can travel and do stuff. So, a couple of minutes, I guess. Just a little bit about our ECHO program. I have two of my young students here that actually I have four students from in my program here from app. I have difficulty saying your college name. I've been told not to say it because my Boston accent. Appalachian. They told me they would throw something at me. So it's App State all the way. So sorry, I apologize. So I do want to tell you that there's a huge need because think about it. What we do is we are the eyes of the cardiologist, right? So, there's a huge shortage of imagers out there. And right now, even because of COVID, it's actually been even worse. A lot of the older sonographers have retired. And so there's a huge need for these people in the field. Actually, last year, US News talked about the best jobs out there. The #1 job was a sonographer, looking at people's images of people. So that's good if you're looking like, I want to go to a school for 1 year, learn a special technique that I'll have a job, which would be good and pays good money. So, which is good. But you also, it's interesting. It's a challenging field to learn. You may think it's just easy. You put a little gel on a transducer, you just slap on someone's chest, but you're obviously imaging between ribs and depending on people's body habitus, as males, females, et cetera, chest cavities, pectus excavatum, lungs, COPD, blah, blah, blah. So it's not as easy as it looks technically, but you also have the machines. These machines are like $250,000. They do 3D imaging of the heart. They do all these amazing stuff to image the heart. But what's interesting and what I love about the field is that you're a part of the heart team, obviously, which is cardiologists, nurses, surgeons, et cetera. But it's incredible about like respect. Like we interpret echocardiograms with the cardiologist, and we have to like do an echo and obviously look at someone's heart, know there's a pathology, work the pathology up. And so they treat us like gold because we are getting the information that helps them make the interpretation of whether that person, like I said, goes to EP or the cath lab or goes to surgery. And it's, like I said, that it's really sophisticated for sure. But this is one thing I know I travel a lot, but people complain about their job, like, oh, I do this. I wish I got paid more money. I'll be like, but do you love to do echo? They're like, yeah, I love it. Like they love to do it. They love that they have a job that can just look at people's hearts and you guys love it so far, right? Thumbs up from the quiet group in front. Okay. So our program is a 1-year program at Duke. It's the only school in the world, actually. This is why I kind of came and developed. Nice meeting you. Take care now. All right, you're good. So something I said, I guess. So you didn't like that answer. Okay, moving on. So it's the only school in the world that's actually at the School of Medicine level. So you actually get a School of Medicine certificate when you graduate, which is pretty impressive. Previously I taught in Connecticut for 19 years, and I had developed the first echo school in all of New England that did adult and pediatric. And we had a pretty good success rate of, placement of our students and pass rate, as you can see, 100%. And we're nationally accredited. So this is our 3rd year now at Duke, and we are nationally accredited, and we are continuing with the whole 100% pass rate. So we think that we pretty much have a really good program, to say the least. And then we also have a 6-month add-on program where you can do pediatric echo. We do obviously all congenital heart disease. So last year, one of your apps guy, Nick, actually won the Student of the Year from our big society, the American Society of Echocardiography. And another one of our students, Daisy, she actually won this other award, which is the actual top student in the country. So actually last year, 7 of my students, I have 8 students in the class, 7 of the students stayed at Duke, and Daisy actually went to Ohio to Good Hands, All-State Hospital, Children's Hospital, to do pediatric echo. So we have great students like you guys, obviously, and we have placements all around the country. My students have gone everywhere. So if you're interested in going to Denver, I know the head cardiologist there, we get you a job there, or whatever you want to go to California, etc. So we have good placements everywhere. So our application is online, and I'm sure Dr. Kappas can obviously pass it on to you, obviously. But we basically just have you do, you know, your transcripts, letters of reference, which you've written many of them in the past for my students, one personal, one professional essay, a little fee for that. And we usually do an in-person interview just to kind of get to know you. But I definitely advocate, if it's possible, that you come in and shadow. So if I meet anybody today that's interested in the program, if you want to travel out to Duke, we can set up where you come in and shadow in the morning, meet with, you know, the staff, you can meet with some of the current students and talk to them, but it's a pretty cool field and love you guys if you're interested. And I certainly will stay afterwards, and Mona and Grace give you a student's perspective too, if you'd like afterwards. So any questions? It's about time, right? Good. I talk fast, so it was really a 2-hour talk, but I kind of condensed it to 45 minutes, so. No, yes. All right, y'all, thanks. Because usually you're pretty tough. Is that okay?